In this chapter, we will discuss therapeutic communication, a crucial tool towards the formation of a therapeutic relationship and a vital skill in accurate assessment. Unlike your everyday communication, what makes communication therapeutic is when it's focused on the patient, their goals, values, preferences, and needs. It's also scientifically based such that we consider how we communicate with someone such as their age, developmental level, and health literacy level. Research shows that effective therapeutic communication can contribute to improve recovery rates, facilitates a sense of protection and safety for the patient, improves their satisfaction with our care, and results in greater treatment adherence. So before you put yourself in such a high expectation, remember that communicating and interviewing assessment skills are all acquired skills and need a lot of practice. It is normal for nursing students to feel scared to say the wrong things. Give yourself grace. I would encourage you that after you have interactions with patients, even if it went well or not, debrief with yourself on how you could have said things differently. This is the purpose of the individual process recording or IPR assignment you will submit with your clinical packet. It will help foster your professional growth. It may even help minimize the use of non-therapeutic communication. The transactional model of communication refers to the continuous exchange of information between at least two people towards forming the therapeutic relationship. Each person is both a sender and a receiver of the verbal and the nonverbal message. With each message exchanged, the other person is decoding or interpreting what the other person is saying. Believe it or not, our nonverbal messages can be more powerful than what we say. If I told you I was feeling happy but looked like this, would you believe more on what I said or how I look? As we all know, sometimes what we say and how we look don't match or are incongruent with each other. This can be confusing to the person we are communicating with. When we find this is happening in our practice, we apply therapeutic communication techniques to get a more accurate understanding. Now, there are a variety of factors that can affect the way that we communicate that are both covert and overt. These can be personal, environmental, contextual, and relationship factors. Personal factors such as our mood, our ability to process information, language or cultural barriers. So, for example, physical or physiological factors that can affect the way that we communicate, such as feeling sick or maybe having low blood sugar. For example, if I'm not feeling well, I may be more easily irritable or short when answering questions. Someone who has clinical depression, for example, may have depressed and anxious mood. This can affect the way that they think. They might show slowed or delayed thought process, as evidenced by their speech, maybe even being indecisive. They might speak in a low, soft volume and may have poor eye contact. Language or cultural barriers. Maybe someone doesn't speak as good of English as you or is not really understanding what you're asking of them, especially when you're using medical jargon. Or some things like touch can be a cultural thing. In some cultures, touch is acceptable and in some they're not. Environmental factors such as the layout of the room, how you sit or stand in relation to the patient, how much space you have between you and others, or even the temperature in the room. Relationship factors. So how we communicate with colleagues will be different from our friends and patients. And you also have to consider that you are in an authoritative or power position compared to the patient. And so that dynamic might also play a role in the way you guys communicate. So we have two types of communication. We have our verbal and our nonverbal. Verbal are any sounds or words said aloud. Nonverbal includes your physical looks, the way you dress, how you present yourself, the way you move, your facial expressions, gestures or hand movements, your eye contact, your vocal cues, or paralanguage. These are all elements that you would note in your mental status exam because it can tell a lot about a person and maybe their in what condition they're in at that moment. So when our verbals match our nonverbals, it's said to be a healthy way of communicating. But when they don't match, that's when the message can become ambiguous to the receiver. This is where therapeutic communication techniques can come in handy. If you find yourself during an interview questioning in your mind or unclear about what the patient is communicating, these can be indications that therapeutic communication techniques should be considered or used. So we've discussed the basics of communication, what can affect it, and what they are. So how can we begin to show congruency in our verbal and nonverbal behaviors? Attending behaviors are the nonverbal language that support our role as counselors, aid effective communication, and show our respect for the patient. Kinesic communication, which is the type of nonverbal communication made by our body movements and paralanguage. Proxemics, which is the physical distance between individuals. So in the US, intimate space is kind of defined by up to 18 inches. Your personal space is defined by 18 to 40 inches. Your social space is defined by 4 to 12 feet. And public space is anything about 12 feet and more. So proper proxemics is important to consider, especially when you're dealing with someone in some sort of crisis. Getting too close to someone who's very anxious or agitated can increase their anxiety or agitation, when especially you get in their intimate space. So you want to be mindful if ever you're in that situation. If you notice that they are getting more agitated or anxious, then taking a few steps back and kind of reevaluating your physical distance from the patient that's in crisis can make a difference. In Chapter 6, we discuss respect as one of the conditions of a therapeutic relationship. Active listening is a way that we can show respect to the patient. If you were a patient, how would you feel if the nurse interviewing you was also busy, looking or doing other things? Would you really feel like they're listening to you? By giving people our undivided attention, it shows that we are fully present with them and thus a genuine interest in what they have to say. Active listening entails our nonverbal language. When we are sitting with someone, we want to sit squarely or at a comfortable angle facing the patient. We want to have an open posture. Folding your arms over or crossing your legs can sometimes make you look like you're closed off. Leaning slightly forward shows that you are attentive and listening. Making some sort of eye contact with who you're speaking with, and the frequency and intensity can vary. Someone with an intense degree of paranoia may not welcome eye contact the way someone with depression or anxiety might. You also should be mindful about cultural implications to eye contact. Some can view it as intimidating or a sign of disrespect. And lastly, having a relaxed or comfortable posture while you're interacting with a person. These are examples of therapeutic communication techniques. I will briefly go over each one, but we'll defer to Table 7-2 of your book for further explanations and examples of each. It will be important to be able to generally identify the difference between therapeutic and non-therapeutic examples of communication. Nonverbal therapeutic techniques include accepting, using silence, and offering self. Using silence is an awkward one for a lot of people, but it can be therapeutic, especially in situations where maybe the person might need some time to think a little bit more, or maybe somebody just received some really bad news and they don't necessarily need someone to talk to feel better, but they might just be happy with someone being present and sitting with them in silence as they either think things through in their heads or just want to vent out loud. Giving recognition to something you've observed a patient doing, such as, "I see you joined group this morning." Giving broad openings gives a patient control over what they want to talk about. General leads encourage the patient to continue what they're talking about. Placing the event in time or sequence can be helpful for both you and the patient in understanding how or when things occurred. This could be helpful to use when you are talking to someone whose stories may be all over the place. It does help provide context and clarification and more accurate understanding of how things have unfolded. Making observations about the patient's behavior or appearance gives feedback to the patient on how they're being perceived by others. This is a good technique if you want to point out incongruencies or you notice something about them you want to explore, but the patient hasn't made the move to. So an example could be, "I noticed when we spoke about this topic, you started tearing up." Encouraging description of perceptions mainly refers to asking about anything dealing with one's senses or perception with the goal of putting it into their awareness. For example, "Tell me more about the voices you heard leading up to your hospitalization." Encouraging comparisons can be useful in helping the patient see maybe personal changes. For example, "So you did this before and it didn't work out. And what would you say is different now?" Restating. There sometimes can be a main idea or theme of what the patient is saying, so restating helps to confirm any understanding or help clarify anything or encourage elaboration. So for example, if the patient asks, "How do you feel about my refusing to attend group therapy this morning?" Instead of answering their question, you would repeat the main idea back to them. So it could be something like, "You want to know how I feel about you refusing to attend group." This can be coupled with reflecting. Reflecting those themes or feelings or emotions back to the patient sometimes can help with the patient's problem-solving skills. This is an alternative to a non-therapeutic skill called giving advice. So an example of reflecting could be, "How did you feel about refusing group therapy this morning?" Focusing. This is putting more emphasis, redirection, or discussion into a single topic, idea, or word. It can help with someone whose thoughts are all over the place. An example of this could be, "Tell me more about insert topic here." Exploring. Maybe you've identified while the patient is talking something important or relevant, an issue, situation, or theme. Maybe the patient discusses something you feel might be significant for either your understanding or the patient's understanding. Giving it more time for exploration can be helpful. Seeking clarification and validation. Maybe on things not clear to you, ensuring you and the patient are on the same page. These can be said before, during, or after a conversation. For example, "I want to be sure I understood you correctly." Or let's say you summarize everything that was said and you follow it up with, "Did what I say match how you understood it?" Sometimes it can be good to preface or follow up with these statements and questions to lessen defensiveness. Presenting reality. You explain your point of view of the situation while also understanding it might be real for the patient. This is a key communication technique for those presenting with perceptual disturbances, such as hallucinations, delusions, illusions, depersonalization, or derealization. Voicing doubt about the person's perception. This is meant to offer a different perspective and does not mean you agree or disagree with them. Again, another key technique for those presenting with perceptual disturbances. Verbalizing the implied can be helpful when the person is vague or unable to effectively communicate their thoughts and feelings. Attempting to translate words into feelings can be helpful when the person uses phrase or words that maybe are symbolisms of their feelings. For example, if they tell you, "I feel like I'm drowning," you may respond, "It sounds like you have a lot going on right now." And lastly, formulating a plan of action. These are questions that can be helpful for the person to problem solve, especially when they want to be proactive in having a plan or multiple plans if a situation reoccurred in their life. Now we will go into non-therapeutic communication techniques. These are listed on the slide but can also be found in your textbook on Table 7-3. It would be helpful to review the explanations and examples presented. It also provides a therapeutic alternative to each non-therapeutic response. When we use non-therapeutic techniques, it can prematurely end the conversation, discourage the patient from further exploring, or prevent us from gaining more insight into the person. Giving false reassurance, saying things like, "Things will get better," or "You'll do fine." Really, do we know that things will get better or that they'll do fine? Most likely not. We can't predict the outcome of a person's situation. Approving or disproving, agreeing or disagreeing. In essence, these pass our own judgment or opinions about the person's actions. This can be non-therapeutic, especially with individuals who are dependent on what others think of them. Without knowing, it can affect their self-esteem or self-confidence, especially when they do something that you disapprove of or disagree with. Giving advice. So if a patient comes up to you and says, "I don't know if I should take this medication. What do you think?" Well, if you give them your opinion, then you're giving your advice. So instead of doing that, we would revert it back to the patient. Maybe say something like, "I'd like to hear what are some things you're considering in regards to this medication." Probing. This can teeter into excessive questioning or asking questions without considering the context. For example, if the patient's behaviors are implying that they're uncomfortable or they're starting to get defensive, but you keep asking questions about the topic. This can happen especially if you're not fully present and picking up on these cues. Defending. This can make a person feel like you're not supportive of them. Even if you don't agree with their actions, it is vital to still show support to maintain the therapeutic relationship. So, for example, this could be maybe defending the actions or decisions of the doctor or your colleague. Requesting an explanation. In other words, asking why questions. When you ask someone why, it might immediately trigger defensiveness. I've met many students who are scared to ask why, and sometimes it just slips out. And I think that's okay because you're still learning, and most likely the patient understands that you're still learning. So they are a little more lenient with you guys. If you see that your patient has taken defense in you asking why, I would correct myself, apologize, and try to rephrase that question in a therapeutic way. So maybe I might say something like, "I see that what I said didn't come across the way I would have liked to. I'd like to rephrase it." And by doing this, you're showing a few things: your humanness to make mistakes, modeling alternative ways to communicate, and also maintaining that therapeutic relationship. It's helpful to understand what your intentions are as well. I find with myself that when I say what my intentions are, it's helping the patient understand where I'm coming from. I'm not asking questions just because I want to be nosy. I'm asking questions because I want to understand them better in hopes to provide better care. Indicating the existence of an external source of power. Using the examples in the book, asking, "What made you do this?" indicates that something or someone other than the person themselves is the source. While this could be true, it doesn't give the possibility that the person may also have some accountability in the situation. Belittling or minimizing feelings. This can be felt secondary to some of our other non-therapeutic responses, such as giving false reassurance. Although most people have good intentions or would like to try and make the person feel better, these statements can be more harmful than good. Making stereotyped or cliched comments. These can be phrases that are typically said in a given situation by many. It can come across as rehearsed or robotic or not genuine. Using denial. Using phrases that send the message of disbelief that something the patient feels is real to them is not actually happening. Interpreting. This is like telling the patient what their experience is like without allowing feedback from the patient. And introducing an unrelated topic. While this can happen during interviews as you're practicing, it's important to consider the topic at hand and its relevance or significance for the individual and their situation. For example, if they start talking about something related to their thoughts of suicide, and your next question has to do with what they ate this morning. So you can see even though it's a very black and white situation, it can become non-therapeutic when we miss this mark. So it's good to kind of assess, why did I not explore that suicidal ideation even more? So providing useful feedback. Sometimes we're not aware of how our actions can come across to others. Or maybe we do, but if no one says anything about it, we may think that, hey, it's okay to continue these actions. In either scenario, feedback can be helpful to provide insight on how one is perceived by others. Feedback is a component of the transactional model of communication and is essential for effective communication. It can best be received from those who the individual trusts and has developed a therapeutic relationship with, to especially decrease any defensiveness. When we provide feedback, we are pointing out behaviors that are observable, specific, and can be changed. The timing of delivery also matters, and giving additional information about how to make the behavior change so that the patient can decide what to do about it. This might be in a situation where you feel you want to tell the person an alternative of what they should do. We already learned that giving advice is non-therapeutic. Instead, we share resources that the person could look into if and when they want to change the behavior. For example, if I told you, "You were being rude to me this morning," are you able to visualize someone being rude? Sure. But if you ask 2 other people what rude looks like, do you think the 3 of you will imagine the same thing and give the same answer? Most likely not, and this is what makes the objectivity and specificity of providing feedback important. It puts everyone on the same page on what behavior we are referring to. Is being rude a behavior we can modify? Possibly, but it would be more helpful to know what exact behavior or behaviors I took as rude. So, to make this feedback more useful, I could change it to something like, "I didn't appreciate when you were yelling at me this morning." In this example, yelling is a behavior that can be modified. It's specific and objective, such that it can be experienced by at least one of your senses. In either example, which statement would make you feel more defensive? If I told you you were being rude to me, or that I didn't appreciate that you were yelling at me? Most likely the rude comment, as it sounds more like I'm judging you as a person. Giving feedback also needs to be well-timed to promote changing behavior. In this example, it would be more effective to say on the same day, maybe within hours of it occurring, than telling this person a week later.